Happens. I'm with Sneed, the Chief Clinical Officer of the Next Door in Nashville, and Cindy's going to be talking to us today a little bit about what she does here and also a little bit about crisis services. She's had that experience in the past, and actually I'd like to start off with that, Cindy, to talk about that. If you can talk about what your role was in the past in the crisis area and what types of crises you responded to in that role.
Okay, thanks, Chris. I appreciate the opportunity to do this. I actually served at the Mental Health Cooperative here in Nashville as the Director of Psychiatric Services until about 5 years ago. I started there as a mobile crisis response counselor and moved into the supervisory role, and then eventually became the director of that program. And as the Director of Psychiatric Services, I was responsible for overseeing crisis counselors and triage counselors who were providing 24-hour a day, 7 days a week, 365 days a year, crisis assessments and interventions for all of the greater Nashville-Davidson County community.
What agencies contacted you to conduct assessments? Maybe you could tell us how that process worked.
Okay, basically in Tennessee, each county has a designated crisis response agency or program. And in Davidson County, the Mental Health Cooperative is responsible for providing those services. So anyone who is uninsured or is on the TennCare roster, if they go to an emergency room and they're presenting for psychiatric reasons or alcohol and drug problems, those emergency rooms would contact the Davidson County Mobile Crisis Response Team,
okay,
which was a part of my responsibility.
All right.
The Metro Nashville Police, Davidson County Sheriff's Office, we made a partnership in 1999 with Metro Police, and through that partnership, we actually created a general order, or what you might know as a civil agreement, that when the Metro Police or anywhere in Davidson County and see a person they believe needs a psychiatric assessment on a more urgent or emergent basis, they can take that person into a protective custody status and bring them to the Mobile Crisis Response Team.
All right.
Through a walk-in center at the Mental Health Cooperative we established. So that's anywhere from 70 to 100 something calls a month just from the
Wow.
Metro Police. So
okay,
on average, the Davidson County crisis team will see 32 face-to-face crisis assessments in a day.
Wow.
That's normal for Davidson County.
Are all the crisis assessments done in person? Is anything done on telephone or anything?
No, everything's done in person.
Okay.
Because it's called a catchment area, the area that is designated for each county.
Okay.
If a person, say in Sumner or Wilson County or Williamson, drives into Davidson County, wherever they happen to be, at ER or at Green Hills Mall, and they need a crisis assessment, they become the responsibility of the Davidson County Crisis Team. So it's called a catchment area.
Mm-hmm.
So essentially anything that happens in this county is the catchment responsibility of that team.
Okay. Okay. Now, if a person wanted to contact, a person in crisis wanted to contact the crisis team, could they do that? Or would you always just respond to an agency like the police department, or how did that work?
Oh no, absolutely not. If a person, there's actually two crisis lines available for Davidson County.
All right.
One is the crisis line that both are manned 24/7.
Okay.
But one is more of a warm line. It's called a chat line for anybody who just needs to talk to somebody they're feeling down, feeling anxious about something. They can call this number, and that's 744-7444.
Okay.
And that's the warm line.
All right.
Now, if you are someone that you feel like you need to be seen, you need to get in to see a provider, psychiatric provider. If you need, many times it's family members that are calling about one of their loved ones that is too ill or is refusing to come in to be seen, but clearly their symptoms would indicate that there is some level of intervention that's necessary. So we go, the crisis team, We go out into people's homes, into schools, up until now it's probably been more like 5 years now. The state divided the children and adolescent responsibilities for crisis response services from the adult services. So for most of the existence of crisis teams, the crisis counselors were having to see both children and adults. So you know, if you go out on 7 calls a day, you may see a 71-year-old man with dementia in his home, and then, you know, 3 hours later be seeing a 12-year-old in the Vanderbilt emergency room. Wow, that's quite a responsibility. It is, and you know, understanding the mental health needs of people across the lifespan is challenging, especially when you're seeing them in crisis all the time.
So what would be some of the options for these folks? You go out and you do this kind of an assessment. A person is imminently at risk for committing self-harm. What are some of the options? What would you do with those folks?
Well, in Davidson County, it's probably the most progressive county in the state of Tennessee in terms of crisis services. I say that because when I started in mobile crisis, we really didn't have a lot of options, and that's been 10 years ago, more like 12.
Okay.
When they present in a crisis like that, you either send them to the ER, or they come to the ER. You send them to the psychiatric hospital, and with managed care, many of those people will not meet criteria to meet inpatient criteria for medical necessity. So you have to look at alternative levels of care or lower levels of care. So I started learning early. We've got to have, you know, for the preponderance of people coming through that had similar needs, there had to be other levels of care that we could provide for crisis resources. So when I say to someone who's having thoughts of hurting themselves but doesn't have, you know, done a suicide risk assessment, and they're not, you know, in imminent risk of harming themselves, you know, what could we do to help that person to provide support for them in that moment without having to hospitalize them? Because you know, there is some truth that things look better in the morning. So if we can get them through the night and try to get some resources available, then that person has the support they need many times. So we developed a continuum of care for crisis services in Davidson County. So from that point, you know, we obviously try to use the less intrusive, least restrictive level of care first. You know, we want to, you know, give a client or consumer the opportunity to take control of their own crisis situation, you know, to be empowered to take care of this next time, you know, with appropriate resources. So,
and what would be an example of a lower level of care, a less restrictive form of care?
Well, an outpatient referral, but many times if you have no insurance, getting an outpatient referral is really challenging. If you have insurance, even, you know, you may have to wait 2 weeks, sometimes maybe longer, to get in to see a therapist or a counselor. So that may not work for that person. That may be too far off. So we created an intervention called the Crisis Resolution Center. It's located at the Mental Health Co-op, open 24/7. So when a person just really needs to talk to somebody, you know, the old talk them off the ledge scenario, when they're not actively suicidal, but they at any minute without appropriate support could go in that direction. That person can come in and sit and talk with a counselor, can be there for up to 12 hours. Sometimes that's just providing basic needs like food or clothes, and a safe person to talk with.
I see.
And then at the point of resolution of crisis, then you help them from there. What now can we do for a long-term solution to try to get you from here and into some other services? If the CRC doesn't work, then you may bump them up to another level of care, again moving toward more restrictive, which would be respite. That's up to 72-hour stay. You can stay there. They have support groups. It's basically like a house with awake staff. You can be seen by a psychiatric provider on an emergent basis there as well. So you can go and stay there, again, basic needs met, also someone to talk to. It's an ideal place to help someone get back on their medication. You know, that otherwise, 10 years ago would have had to go into the hospital for that.
Exactly.
But now won't meet criteria.
Sure.
Because they're not, at imminent risk of harm to self or others.
Okay.
So if respite doesn't work, and they're let's say they're even closer to a hospitalization, a psychiatric hospitalization, there's a new program that's only a little over a year old in Nashville, called the Crisis Stabilization Unit.
All right.
It was the first of its kind in Tennessee, and now there's 4 across the state, and
Wow.
they're hoping to add more.
Okay.
All of this is the continuum of care for the mental health co-op here
Sure.
in Nashville. So the Crisis Stabilization Unit, or the CSU, is one step from hospitalization. It's the most restrictive, but it's all voluntary.
Okay.
All of these are voluntary. So
Sure.
a client could at any point say, I don't want to do this, and walk out. So
Mhm.
they have the right to do that. And if the CSU, you can stay there up to 72 hours. Again,
Mhm.
another place to restart medication. There, it's actually is staffed with nurses and counselors and case managers.
All
So
right.
there's 24/7 staffing there, but it's a little bit more medically based.
Right.
So if, let's say, a detox protocol was
Mhm.
necessary for someone, you can't do that without, in many cases, without a nurse to
Sure.
monitor vitals,
Uh-huh.
etc. So all that's done at the CSU,
Okay.
which averts a hospitalization and the stigma that comes with being hospitalized for your mental illness.
Right.
So the CSU has been a huge success. And, for people who have no insurance, there's only one hospital in Nashville that you can present for psychiatric admission, and that's the state hospital, which is Middle Tennessee Mental Health Institute.
All right.
Now, the little known fact is that you can't get in that hospital unless you're involuntarily committed.
Okay.
So if you have insurance, private or commercial insurance, you can get into, or TeamCare for that matter, Medicaid, you can get into any of the other private psychiatric hospitals in town, provided a bed is available.
Sure.
But if you don't have insurance, you have to be involuntarily committed,
Okay.
which is a real issue for counselors.
Sure.
And, that is tough.
Exactly.
If they're saying I'm willing to go, but you have to involuntarily commit them, that's a big struggle and
Mhm.
negotiation there to
Sure.
try to figure out how to handle that situation. But if a hospitalization is necessary, if they're too high risk for the CSU,
Mhm.
and knowing that they could just leave,
Mhm.
it may be necessary to take that additional step.
And is there a law or some sort of guideline which states how long they can be committed to an institution involuntarily?
Yes. In fact, I'm not exactly sure, it's been a while, but
Okay.
in the Tennessee Code Annotated, it addresses the civil and judicial commitments.
Mhm.
And in Tennessee, the what they call mandatory pre-screeners,
Mhm.
they're crisis counselors or mid-level providers, like a licensed professional counselor with mental health service provider designation,
Mhm.
a licensed clinical social worker. There's several in that mid-range category that going through a state certification can be a mandatory pre-screener.
Okay.
So I can write the first 6404 or involuntary paper.
Okay.
So when you're connected with a crisis team. So I might assess that person and go, in my clinical judgment based on these facts, I don't feel like they're safe to be out in the community
Right.
without this essentially taking their civil liberties away.
Exactly.
So it's a very big responsibility.
Mhm.
But all my CON or 6404, a certificate of need, all it does is ensure safe and secure transportation to the hospital. And then at that point, a psychiatrist will do another assessment.
Okay.
And that psychiatrist has to agree with my opinion and then write the second 6404 or CON in order for that commitment to take place.
And that's presented to a judge for review
after 72 hours.
after 72 hours.
So for the continued stay, there's another piece of the process where they have intervals they go before a judge at MTMHI
Okay.
to determine whether or not they in the psychiatrist's mind in the eyes of that judge that they are safe and there are enough community resources that are appropriate for that client or consumer to go back to the
Right.
community. So you know, in this day and age, with the budget cuts in Tennessee, you know, they're and the Department of Mental Health is responsible for all the state hospitals. And we just received word in the past month that they're going to be closing over 100-something beds for the state hospitals.
Holy
so
cow.
It's getting more and more desperate for people with no insurance.
Sure.
So it's putting a much bigger burden on emergency rooms where people are presenting because they don't have alternatives.
Exactly.
So it's ideal that the CSU exists now and is in other communities. There's one in Knoxville, in Chattanooga, and Memphis, and I think they're trying to build 2 more in the next year.
Okay.
So
there continue to be challenges.
Oh yeah.
This way.
Absolutely.
Well, speaking of challenges, Cindy, what were some of, looking back at your experience on the crisis team, what were some of the major challenges for you personally, professionally, in doing that kind of work?
I think professionally it was challenging because what I knew when I left graduate school was great information, but I still lacked a whole lot of information.
Sure.
I needed to know more about mental health law, a continuum of care, how to recognize different levels of care, and making appropriate referrals for a person's needs, their presenting needs, as compared to what their standard needs are.
Right.
You know, someone who has schizophrenia is always going to need extra support.
Sure.
But they may be presenting to me, you know, even though they have schizophrenia, you know, at a time when they're having thoughts of suicide. So I have to deal with immediate needs, but also need to make sure that once they're discharged from a hospital or any of those levels of care, that they've got appropriate ongoing care.
Exactly.
So you don't always have that. So finding those resources was huge.
Okay.
That was a big learning curve for me. I would also say, just, you know, professionally and personally, just keeping the stamina of doing crisis work is hard. They say the average lifespan in the work for a crisis person is 2 years.
Wow.
And you understand that when you're doing it.
Exactly.
You know? So you're hearing people in their most desperate times all day long. And, you know, the hard part is that, you know, you can't create a resource on the spot for them.
Right.
You know, you have to work within the system. And one of the things I learned in school is that you have to trust the process. You do your part, and you hand them off to the next person.
Right.
And in crisis work, that's the hardest thing to do.
I bet it is. Because
you want to know that the next person is going to provide the same quality of care, and that they're not going to get lost in the system somewhere. Because you have liability concerns as well as just human concerns for the well-being of that client. So I think as a manager of a program like that, you know, you always have Monday morning quarterbacks in crisis work. How the head physician at that ER would have preferred that situation be handled, but I can't make a bed appear for a psychiatric hospital. So if there's no beds, and that ER director wants me to hospitalize somebody, they also have to meet medical necessity criteria.
Right.
So you're always caught in the middle somewhere. Because as a crisis counselor, what you do is more of a screening and assessment process.
It's not really a therapy type deal.
And there's a big difference. It's knowing what those boundaries are.
Sure.
There are times that it's appropriate to do a more counseling type intervention. When someone's girlfriend just left him. You know, he goes out, he gets drunk, he's desperate. He's never tried to hurt himself before, but tonight he said it for some reason. The police bring him in, and there he's sitting there. He's saying, "I didn't really mean it. I'm just hurting." That's an appropriate intervention. Then, you know, a skilled counselor can dig right in, and, you know, brief solution focused therapy works really well. In those situations, and you know, CBT seems at times a little bit harsh for people in crisis.
Behavioral therapy.
Yes, because, you know, I don't sit here and tell me that the way I'm thinking is causing my behavior.
They don't want to hear that.
They don't want to hear that then. They need something a little bit warmer, a little bit, you know, if the miracle came today, what would need to be different in
Right.
your life?
Uh-huh.
You know, just trying to help people find their way again,
Exactly.
without having to continue to deteriorate in that, you know, that downward, you know, spiral until they really do become long-term mental health patients.
Exactly.
So I think personally as well, you'll hear stories that you just don't think could ever be possible.
Mm-hmm.
You know, there's a lot of abuse, a lot of not just abuse of children, but adult abuse,
Uh-huh.
like elderly abuse.
Right.
And you go to people's homes and you see how they live, and your heart breaks for the way some of the folks live,
Sure.
and right here in Nashville.
Yeah.
That you have no idea, and it doesn't matter how nice that house looks on the outside. There's always something else behind that. So a lot of family stuff that is very heartbreaking.
Sure.
But I think being able to find a way to leave it at work was a challenge.
Okay.
And I really felt like my role, most important role, was to help the counselors stay healthy.
Okay.
Because I had 28 master's counselors, most of them were licensed, and 9 triage counselors who did nothing but man the phones.
Oh, wow.
And so, you know, there were a couple of notable moments when, you know, someone says, I've got a gun, I'm going to kill myself on the phone.
Wow.
And they're clearly intoxicated.
Sure.
And then you're just about to get the address and they hang up. And so, you know, that leaves that triage counselor just, you know, with an unbelievable burden.
Sure.
So working through that as a team is really, you know, was a real challenge.
Yeah.
And those pictures of some of those people, you know, when they are so sick and so paranoid that the police are having to handcuff them and wrestle them to the ground so that they don't hurt someone or hurt themselves, or, you know, those are hard. Those are hard to watch, those things. And, you know, they did not invite mental illness. It got there before they even realized what was happening to them. One case in particular that was very challenging for me was a young man who was a student at one of the private colleges here, young African-American student, brilliant young man. He was in his freshman year and he had his first psychotic break.
Wow.
He came on a full scholarship to Nashville, and his parents were both physicians in Orlando, Florida. I'll never forget this. And his roommates were starting to get concerned about him because he stopped eating, stopped going to class. He always thought somebody was trying to get at him when he was asleep. You know, so he thought people were trying to poison him. He would literally take pillows from his bed and shove them up under the door at night to keep, you know, the demons from coming under the door. And I mean, he was incredible. He was terrified. He was terrified. So the dorm resident assistant called the police, and they brought him to the mobile crisis area, to the walk-in center, and we assessed him there. And we got on the phone and called his parents, told them what happened, and they were devastated. I mean, it was
Can you
not
imagine
using
getting
drugs.
that phone call as a parent? That must have been
and
horrible.
I mean, they were like, we will get there as quickly as we can. Please don't do anything with him until we get there. And he became paranoid to the point he became unmanageable and became unsafe. So we had to go ahead and hospitalize him before they could get there. But I mean, he was sick, and you know that's going to continue on his lifetime, through his life's journey. And you know, knowing that you can't stop it, you know, all you can do is treat symptoms. It's hard, and knowing that you did your best and that's the best and all you could do is you have to really learn how to balance that. Fortunately, I've got a great support system outside of work, and great friends at work, and you know that really helps. And having other counselors to talk to, you know, other professionals really helped me.
Yeah, so that support network is so critical.
Oh, I couldn't have done without it. And there are times I didn't realize how much I needed it until I was talking to somebody, and then we all went, wow, that would have been hard for anybody. So that's why I say, you know, helping the counselors stay healthy. When they would come in and they, you know, you could tell when they had just about had all they could take,
Mm-hmm.
and then saying, sit this one out, let somebody else go on that call.
Mm-hmm. Sure.
Or if you know that someone had a horrible experience with children calls were tough, because no one should hurt kids.
No.
I mean, we have our own belief systems at work at all times, and you don't want to know that people hurt children.
No.
And so, there were some of our team that just could not do what we call kid calls. Couldn't do it. So it was just too much. So, but at the end of the day, they get up and do it again, all over again.
It's amazing.
It is amazing. And 5 years later, now 5.5 years later, they're still thriving, and they'll have an opening here or there, and and then, but it's the best training I could have ever asked for.
Sure.
I mean, I had no idea how little I knew about the DSM-4 until my experience there.
It forces you to learn about it.
Absolutely,
Yeah.
and it prepared me well for this new venture.
Sure. Well, to wrap this up, Cindy, if you could just tell us what would be a good way for a student to prepare for this kind of work if they're interested in doing crisis work. What are some good tips or strategies to prepare for that?
I would say at least volunteering, seeing if there's a crisis team in Rutherford County, I mean, for that matter, and through the guidance center. So you could contact the crisis team and ask if you could come and shadow a day with the crisis team. I would strongly recommend that you pay close attention in certain classes, such as any class that touches on suicide, risk assessment in particular. If you, when you're in your pathophysiology class or your psychopharm class, huge. I would also say any time that you're in a class that uses the DSM-4, you need to pay close attention. So there's a lot in the book that you see in crisis world that you don't normally see necessarily in a private practice setting.
Sure.
And you see people when they are most symptomatic in crisis, or they would need you. So when you're seeing that, you go, "Wow, that's in the DSM-4."
Right.
I've read it, but I thought I'd never see it, and it's right here. So you may see a client who's bipolar 1, and you see them 2 months ago, and they were in their depressed state. And then on the unipolar side, you see them 2 months later, and they're as manic as they could possibly be, and really dangerous to themselves.
Sure.
And either way, they're at high risk for suicide. So you just learn, and you get to see all those things put together. But having a solid base in assessment and diagnosis is huge, and then you're pretty well prepared to get out there and start trying. And an internship is always a great opportunity. That would be huge if you could do that.
Yeah. I guess experience would be the best teacher, wouldn't it?
Absolutely.
Yeah. Well, Cindy, thanks so much for spending time with us today, and look forward to talking to you in the future.
You're welcome. Thank you.